side. We had finished out with the femoral triangle yesterday, and once again, I did stretch out, the borders and stuff of that. That's an important area. We were working our way through the muscles of the thigh, then we came back to that triangle, and now we're just kind of finishing up the thigh, talking about the cutaneous sensations. If you remember from yesterday, the anterior compartment of the thigh muscles, almost all of them, pretty much all, are innervated by the femoral nerve for their muscle actions, and that's the same with their cutaneous sensations, so there's no change there. The same thing happens in the medial thigh, where obturator nerve innervated most of the medial thigh, or the adductor compartment, and it's also going to be obturator nerve for cutaneous area. Now when you get back to the posterior side of the thigh, the one here at the bottom, they just named it, instead of, I don't know why they don't name it tibial, they named it because tibial innervates the muscles, but there's branches that come off of that, and officially you have the posterior cutaneous nerve of the thigh. So it's named for where it's at. Then you have the lateral cutaneous nerve of the thigh. The lateral cutaneous nerve of the thigh was that one that came out of the top of the triangle by the ASIS yesterday in that picture. Was the number one there. So that's going to supply the lateral side. So just a visualization of how those actually go. Once again, when we get to the end of all this, we kind of look at our cutaneous sensations again. There's your posterior cutaneous, and here next would be your obturator. So just kind of learning. It's good for us if they are linked. There's no really crazy sounding names that go to them. Then of course you have dermatomes of the lower extremity. Just like we used like T4 for the nipple line, T10 for the umbilicus, for dermatomes on the thorax, the arms, you can use a couple of landmarks to help you out on the lower extremities. And the main ones I use are to say, well, if you were to look at L4, dermatome, it goes right across the top of the kneecap, the patella. And then if you split the gastrocs into medial and lateral sides, on the lateral side here you have S1, and the medial side of your calf is S2. And so it gives you can estimate and count up and down from there. To me, the only time you're ever going to be asked by somebody like me and look at a dermatome, have to count them, whatever, it's a textbook thing. Because truthfully, when you get into clinic, if you're going to do a dermatome, a real dermatome check, you should have either a computer or a piece of paper. So it shows you the dermatomes on it. You know which ones you're marking on. It's like what's those sheets called in the ER? Like the patient comes in, you pull, it's a respiratory. Forget the name. Y'all are all looking at, well, you're the PA, you should know. y'all PAs too soon. I tell you what, I will say something about it. If I can remember what they're called. In the ERs, a lot of them have patient sheets. And they're like one sheet front and back. I forget the name. And maybe they don't. They haven't been in the ER. Well, I have been in the ER since recently. I wasn't working there. But they have these like stat sheets or something. And you pull them, and it's like doing a physical exam. It's a one-page thing where you can quickly look, and they're changed by like, is this a respiratory one, a cardiac one, ortho? And when I went to phase 2, I went down to the ER and they had those, and I pulled all those out. Because there's a perfect way when you're learning to write notes of all the stuff that should be included in it. I wish I could remember what they call them. I might go down and look at the ER for those because it's a quick reference sheet. Popliteal fossa, backside of your knee. Popliteal fossa looks like a diamond shape as you see in the picture there. It's bounded superiorly. Up here is going to be our hamstrings, and we'll discuss specifically which parts of them that are making the top of that kind of diamond shape, and then the two heads of the gastroc are making the bottom. Popliteal fossa is very important because it houses all those vessels. Remember, we have the popliteal artery, the popliteal vein, and when we look at damaging those in that area, could be significant if they were out in front, so they're in back, but you can still damage it. Like I had a first sergeant major that played softball for the first time like in his life here on base when I was in physical therapy. I had to go over and see him. He was up near the burn unit. They had these rooms that were sterile rooms. And they said, hey, go in here and you gotta see this guy and we're gonna start range motion on him. And I went in and he was filleted like an extra eye, all the way open down his leg. And he had all these pins in him holding a stabilizer. And he was yelling at me to get out of his room. Because he didn't want anybody in there because he was gonna get infected. I'm like, no, I gotta come in and see it. And I went in and talked to him. He had slid into second base, kind of hurt his knee, and then he went ahead and played the rest of the game. But by the time he got home, his calf's this big. He had severed part of his popliteal artery, so he had developed significant compartment syndrome. They had split him open. It was interesting. I'd never seen that before. And I guess when you get old, you don't just decide to start playing one. That's why you got to play all sports when you're young. If you played at least once before. How do you go your whole life without playing softball? It's a joke. How do you go your whole life and not knowing how to swim? I don't get that either. But sorry. I had the thought for y'all in my head when I said that. Because there's so many things that I do that y'all would never do. I get it. Right? The truth. Popliteal fossa, if you look on the medial side, and that would be on the left side of this picture, because this would be a right leg, just tell by the way it's angled there, the semitendinosus muscle is here, and then the tendon of biceps femoris is over here. So they make the little side borders of the popliteal fossa. If you look out to the side, you can also kind of make out this is the iliotibial band. So other than that, it's just your gastrocs down on the bottom side of that, and then you have your popliteal artery and vein and your tibial nerve. The tibial nerve is there because we have the popliteal vein, popliteal artery. They're using the adductor hiatus to go back and forth between femoral vein, femoral artery, and then you have your tibial. But remember, the tibial is a branch of the sciatic. The tibial branches and innervates the posterior thigh muscles in that compartment, and then continues on to innervate the posterior calf muscles, just like the radial did. But just a little higher than the adductor canal, the common fibular nerve is going to come off of that and split. And it's going to go and wrap itself around the fibular head on the lateral side. And I'll show you why I'm saying that in a minute. So here's kind of a grainy picture of the femoral artery and vein labeled there. This would be your adductor hiatus. And then they made it to the knee. When you look at the knee and you compare it to any other joint, it has to provide support for the whole body while it's moving, locomotion. It must be mobile, but its only actions are flexion and extension. It's a synovial hinge joint, no different than like your elbow. It's just much stronger. Right? So you would call this a synovial joint, but the type of synovial joint is a hinge joint. And if you compare it to a lot of other joints and you say, well, okay, compare stability of the knee to the elbow. Well, the way the knee's set up, the elbow's kind of locked in, right? A little bit. It has an electron on. The knee does not have that. I said that before. The tibial plateau, right, sits with the condyles on there, and that's kind of a flat surface. So once again, I know I've already said all this, but once again, that makes it where even, I mean, the hip's way stronger, of course. But since these femoral condyles technically can just slide back and forth across there, you must have, again, very, very strong ligaments, the capsule, and specifically your quads. If you've ever had a knee problem, like runner's knee, or you strained a ligament in your knee, one of the best things you have to do is to strengthen your quad muscles, right? Your wall squats, short arc quads. You don't know what those are, don't worry about it. But strengthen those quad muscles because they're going to help keep your, not only your knees stabilized, but keep your patella tracking correctly. And that's one thing that people don't do in the military. I don't know why I got off on this. They have runner's knee, RPPS, retropatellar pain syndrome, patellofemoral pain syndrome, whatever you like to call it. And they get it because, yes, they go and run, but they don't do any other types of workouts. You know, picture the typical private at his first unit in Army PT a lot of times, at least when I was in, and we weren't doing like squat stuff. We were doing push-ups, sit-ups, run, right? And then they don't even stretch right. You know, like, okay, let's stretch. 1, 2, 3, 4, 5. Okay, we're good. Okay, 3. I didn't know any better back then. So the knee has 3 articulations that we're going to look at when we say, well, what about the joint? The femoral and tibial condyles are 2 articulations. So each femoral condyle, where it sits on its side of the tibial plateau there, condyles, is 2 of the articulations. And then the patella to the femur, that is that patellofemoral joint. We already said the fibula is not involved in the knee joints. I love this next slide just for the reason that's the only action, flexion and extension. We will talk briefly about, I'll say it, knee ligaments. All right, so you have the patellar ligament, very large, and then you have the fibular collateral ligament, the tibial collateral ligament. Now, everyone in here who's, our individuals in here who have prior medical, doing knees, doing clinic, we don't call them that. Right? Out in clinic, we say, well, you damaged your MCL, right? Or you damaged your LCL. But they do have real names. So the LCL is the fibular collateral ligament. Well, what side is the fibula on? Lateral side. So the LCL, that we call it, lateral collateral ligament, is the fibular collateral ligament. And the tibial collateral ligament is your medial collateral ligament. Like I said, most commonly, you call them LCL, MCL. And so if we look at how these are set up, this should be our iliotibial band. It's been cut away there. Coming off of here and going down to the fibular head is the fibular collateral ligament. And on the other side, you have the medial collateral ligament, or what's termed the tibial collateral ligament. And then, of course, your big patellar tendon. Are we going to look? We haven't looked at. I'm not skipping them. We will look at ACL, PCL here in a second. Those are deeper into the knee. But also note, look at these 3 tendons. This is a good picture for this. What do you think those 3 comprise? What's the name for that group? Pheasant's ring, pheasant's ring. That's how it looks when it attaches. If we have the whole lower extremity, if we get that tank raised tomorrow, I'll show you, there's a very good example of, it looks almost like that picture. You can lay those muscles and how they connect out, the tendons of them. Remember, that's what's going to stabilize that medial side of the knee. So even though our tibia has that plateau and the femoral condyles sit on top of there, I just need to start you hanging from the ceiling. Don't do that. Well, you say things like that sometimes the next day you come into class and it's hanging from up there. I didn't really mean it. Okay. So it's flat. But luckily, we have some meniscus. Meniscus is just an articular disc. So the knee has an articular disc. And if you look at, it provides shock absorption, but it also helps to control some of the movement that's in that knee. And when you look at an actual knee that's not on a skeleton, you can look at the periphery of the synovial capsule and see that the meniscus are actually in that capsule. So they're going to attach to the sides of that capsule, they're in that capsule. I'm saying that because we've all heard of the ACL, PCL. They're not in the synovial capsule. They're outside. They're in the capsule of the knee, but not in the synovial capsule. So I'll keep mentioning, if you damage the medial meniscus, most often you're going to damage the medial meniscus and the medial collateral ligament at the same time, tibial collateral ligament, because they are connected together. The lateral side, that's not the case. here is our lateral meniscus. And I got some better pictures for them coming up. And technically it's a little more movable than the medial meniscus, almost circular in shape. And when you compare it to the medial meniscus, which has like a C shape and much larger, I used this to show, here's your medial meniscus. If you notice, this is the medial collateral ligament, and it is attached to it. So when you damage that MCL, if it's significant enough and you pull it, you often will tear or damage the medial or the medial meniscus. Then the infamous ACL, PCL. These are two ligaments that cross at basically right angles to each other inside of the knee in what we call the intercondylar fossa. So you're going to find your ACL, PCL. If you look at where this metal is, up in there, and this is called the intercondylar fossa between the condyles of the femur, and those are going to sit in there kind of at an X cross angle. So they're within that knee. And that's going to help prevent forward and posterior and anterior movement of that bone. So here we go, ACL. This would be your ACL. It's weakest of the two. We hear about that all the time with ACL tears. We don't always see PCL tears. If you define knee movement and how it works, you're going to say, well, it's slack when the knee is flexed, but tight or taut when it's in extension. So the easiest way, you're in extension, you get hit from behind, you can tear that anterior cruciate ligament. So what its job to do is prevents anterior displacement of the tibia on the femur. What that's saying is, if I take your leg and I have you like sitting on a plinth with a knee bent, we'll talk about anterior joint stuff here in a second, but let's do it this way. If I take the tibia in this hand, the femur in this hand, if I'm trying to push this way, push this tibia that way, that's going to be stopped by the ACL. ACL won't allow you to do that. So the way they describe it in textbook, you would say the ACL, anterior cruciate ligament, prevents anterior displacement of the tibia relative to the femur. Makes sense? And that's the way we're always going to remember it in here. And I'm just going to mention this because sometimes you'll see it written differently and saying the same thing and it can confuse you. I'm not going to try and do that on the test or anything, but could I also say that the ACL, if this ACL prevents anterior displacement of the tibia relative to the femur, could I say that the ACL also prevents posterior displacement of the femur relative to the tibia? Sometimes you'll hear it that way. The reason I don't even think about it that way or say it that way, and maybe some orthos do, is because even though there's a lot better exams, we're going to do and kind of see and hear an anterior. Are y'all doing that with this physical exam, anterior jaw test? No, not yet. And an anterior jaw test, you're trying to pull the tibia anteriorly. So I just link them all together. Well, anterior jaw test prevents, ACL prevents anterior displacement of the tibia relative to the femur. So we'll stick with it that way. All right. Posterior is stronger, and it is tight, and your knee is flexed. So its job is to prevent posterior displacement of the tibia relative to the femur. So we'll leave it there, and then we'll come back and look at how you would actually do a basic test on that. So we're looking specifically here. They have pulled back with a probe the fibular collateral ligament, or LCL, so that we can see that it's not connected to that lateral meniscus. So it's coming off of the lateral part of this condyle, and then it's inserting down into the head of the fibula that you can't see here. And I need to take out, there's a little bit of repetition here on it, trying to drive the point home that the medial's connected. Lateral's not. So in the lab, we have great knee specimens. I like the specimens we have for the knees more than others because you can really get in there and see, right? Okay, well here's our PCL going this way, here's our LCL going this way, and those two together are going to help prevent that too much posterior anterior movement of that knee. So while this is labeled like crazy, that's the main thing I'm using it for to pick out there. So here's an example of the PCL's tight, right, when the knee is flexed. So here's your PCL, and right now it's very tight. And if you extend the leg, then the ACL is going to be tight. Right. The reason we keep talking about this is because when you get into ortho biomechanics of injuries, and you're looking at how it actually occurred, of course you're going to test the knee, but this lets you know kind of what position were you in when that happened. Of course, a lot of the ACLs I've seen are people, it's always basketball, it seems like. Basketball. I remember when I was in Hawaii, we had a bunch of casualties one day, heat exhaustion, because the Cab Scouts thought it'd be a good idea. Well, not the Cab Scouts, the leaders of the Cab Scouts thought it'd be a great idea to have them go out at 1 o'clock in the afternoon in full knock gear and play basketball. They were dropping like flies. So do you know anything, we got any Cab Scouts, prior Cab Scouts? You know anything about Cab Scouts? They're all a little crazy. I mean, they get wild. And they were acting like they were having fun, because they're dying out there. You were a Cab Scout? That was my first unit as Cab unit when I was enlisted.
Which one?
I was in 5'9" Cab, which changed to 3/4 Cab. I was in 5'9", which is Buffalo Soldiers. I got my spurs.
Good.
Just I knew you were thinking that.
Well, I didn't doubt. But it's good. It's good.
They're still out there. I met some of the Buffalo Soldiers. They were still alive. There was a guy who lived out there in Hawaii. Anyway, it's kind of cool. I'm gonna wear the shirt tomorrow. I still have my.
You should.
We had our.
We
had our own PT shirts back then. They were red and tan. Sorry, we're having a personal conversation. I had to break it up somehow. Y'all were about to fall asleep on it. Hey, bursa of the knee. When you look at the bursa of the knee, there are about 14. No reason even counting them. There are a lot of bursts that surround the knee. Why? A lot of large tendons. They can run a lot of locomotion. In general, when you talk about the synovial capsule of the knee, these bursa are connected. So when you start to see knee swelling, you'll also start to see these bursa swell up. And I'm only going to cover 3 because they're the most common ones that we look at. Like if you're draining fluid off a knee or something, you got a big swollen bursa. The only 3 we have to pay attention to and know is this suprapatellar bursa, which means above, and then you have a prepatellar bursa that's right in front of your patella, and then you have an infrapatellar bursa that is below the knee joint. And that's it. If you go in and look in the books, if somebody's reading the books, you'll see there are a lot more bursa that are associated with that knee. But those are all I need you to pick up on. And a lot of times, the suprapatellar is where you'll see a lot of that swelling occur. You ever seen somebody, they have a knee, torque their knee a little bit, and then they're swollen up all above it? Doesn't mean it's that damaged though. Looks worse than it is sometimes. Alright, so because the knee depends completely pretty much on muscles and ligaments to support it, it's often damaged. And most commonly, if you're going to damage your knee, is when your foot is fixed to the ground and somebody hits that. Like you're running, that foot's planted, somebody hits that leg. Same thing in basketball and things, their foot gets planted as they turn. Whatever that is, it allows a shearing force to happen and you wind up either spraining or tearing a ligament in your knee. Since the tibial side, tibial collateral ligament is connected to the medial meniscus, they often tear together. And I said it once again so that I could go into what's called the unhappy triad of injury. This is what it used to be, you know, before these advanced surgical techniques. This is the kind of thing that would ruin a player's career, because if you have this type of injury such as in football, you have a twisting, strain while that leg's in a bad position, you may tear the tibial collateral ligament. Remember, if you tear the tibial collateral ligament, you're probably going to tear the medial meniscus. And if you manage to take those out and you have your leg in just the right position, you're also going to take out your ACL. So anytime you hear that somebody tore their ACL, their medial collateral ligament, and their medial meniscus, that's the unhappy triad of injuries, your career ender. What's amazing to me about knee stuff, if you look back to when football was actually tough, you know, and we had real players that played it, there'd be people out there playing without, they didn't have the braces, they had some back then, but they would go out without an ACL. They'd blow their ACL out and keep playing without getting it fixed sometimes. And you can go and look up stories of it. And you could do that if you're strong enough, right? They have bulky muscles, large people, but you're not going to be able to cut. And I think about it, well, how could they do that back then in football? Well, you look at linebackers, and you can tell me today, most of them back in the day, they're just going straight forward almost. Now you got 350-pound linebackers doing 4.5 runs. You know, they're chasing people on the outside. If you have a blown ACL, you're not gonna take 350 pounds and make a cut. You know what I mean? So I'm picturing, if you don't know you don't have the visual. I'm picturing like the refrigerator parent. He could probably play with a blown out ACL. He's pretty musculature. He's only going forward. Second thought in my mind, because inquiring minds want to know, is a movie quote. We heard him bad, No, got that one? North Dallas 40. Don't go watch it. It's old. I grew up in the Dallas area, so I haven't mentioned that. Down watch, I look down. I don't need a bunch of cowboy jokes. I grew up when they were good. Me joining, you know when they went bad? I can tell you. The day Jerry Jones fired Jimmy Johnson. That's it. From then on, tell me something good they done. Here we go. Knee joint, severe force-directed injury of the knee semiflex damage your ACL. I would keep saying that. I need to clean these up, obviously, because I'm leading into things where I'm repetitious there. So here's an anterior drawer test. So the purpose of the anterior drawer test, which is not the best knee exam, is to evaluate integrity of the ACL. And so the words you would use, I wrote on there. Endpoint laxity. When you test it, you would have somebody lying back on a plinth, have their leg up like they're in a sit-up position, you know, and so you put them down, and a lot of times we just sit on their foot, you know, and then you're just going to pull. Same thing, you can go forward or backwards. If you're pulling, that's an anterior drawer. You're trying to slide the tibia forward. When you test that, you learn to test that, the first thing you do is test what? Exactly. The good knee. Why do we want to test the good? I'm not trying to teach physical exam, but why do you always test, well, no matter what you're testing, why do you test the side that's not hurt? Exactly. I hear a lot of good answers. They might already have laxity. So if you go and pull an anterior drawer on the bad knee, and you didn't compare it to the other one, you may think it's lax, but maybe this other knee is exactly the same. So easy concept, but not something we always think of, right? Another thing is one of the problems with our ACL injuries is how long since they did it. Like if you run right out on the field and start testing their ACL, you may get a chance to kind of feel what's wrong with it. But within an hour, that thing is going to swell up. You know, not even an hour, and you really can't test it. That's why you got to brace them and have them come back, because the pain, the swelling's holding them back. But that's the ACL. So anytime you're asked, endpoint laxity suggests damage to the ACL or suggests that it might be ruptured if it can move too much. The PCL is stronger, but it can be disrupted. Like one of the ways when they land on the tibial tuberosities, you know, kids do that when they jump on trampolines and different things. I always picture if you were to jump up off this podium, flex your knees and just land on your tibial tuberosities. You're gonna drive that backwards. Or like when those soccer players slide across the field on their knees. Of course, they're pretty strong, so they're not gonna do that. But basically, you're gonna do a posterior drawer test to look at the integrity of the PCL. So endpoint laxity of the PCL actually suggests ruptured PCL or damaged PCL. Before we go into talk, these ACL, PCL, all these letters, I do need you to know them, what they stand for, not just the letters. I'm not going to abbreviate them. Okay. Same thing for you prior medics. If you tell some people things and they've never seen it before, they just remember it that way. Other people are very used to using LCL for the knee. Lateral, collateral ligament. You damaged your LCL, but I need you to know both. Because throughout here, so you're going to need to know that the lateral collateral ligament is the fibular collateral ligament. The medial collateral ligament is the tibial collateral ligament. Okay? So I'm just telling you that so you don't just blow it off and go, well, we always just abbreviated LCL. Then you get there and don't know what it means. Okay? Alright. Trying to be fair there. Patellofemoral stress syndrome, runner's knee. Huge issue along with shin splints, right, in the military. A lot of runner's knee. And a lot of us are running straight through it, right? You're not going to not go to PT for runner's knee unless it's significant, at least in my mind. But the problem with runner's knee is your patella is not tracking right. So you have weakness in one, if you picture your quadriceps, right, you have your vastus medialis, lateralis, and you picture how they're holding the patella there. I don't have a patella on the skeleton, but now we do. It doesn't move. That's awesome. Okay. So your patella's here. If you look at the bottom of the patella, it kind of goes like this, like a V. And if you look at the condyles, that's a groove. And so that patella and its indentation should ride right between those condyles. And as you flex and extend your knee, the patella tracks through there. Okay, so it's going to slide back and forth this way. If you were to have, let's say, like a weak vastus medialis, that would allow the lateralis to pull this to the side. And even just a little bit, you're going to start to rub. Y'all getting what I'm saying? Y'all understand? And so as it does that, it starts to rub on one side, it starts to heat up, and now you got runner's knee. It starts to bother you a lot. So it's a problem with how that patella tracks. If you look, I was thinking more about that. If you look at like basic training, you see a lot of these because they're not used to running yet. They don't have strong leg muscles yet. The easy way to combat this is to strengthen your leg muscles, and it will help you to track. In the meantime, you can tape it. I like to do taping, because I was physical therapy before, but you can tape the patella to help hold it in track for a while for them. And nowadays we know they have. Back when I was enlisted, we didn't have kinesio tape running around. Now everybody, all y'all probably got some at home, right? They didn't have that. Or you can go get the donut brace from Walmart, which really doesn't do a whole lot. Right? It has no support for a knee, but it's good for the fact of patella shocking. It has that patella thing, and it'll kind of help it to stay straight. But if you're putting a Walmart brace on because you feel like your knee is, like your ACL is significantly damaged, that's a waste of time. I once climbed a ladder. This is related with the patella. This isn't a personal one. I was about to deploy. I had about 2 weeks. I was leaving to go to Kosovo, and I had a scenario. You ever seen those upstairs rooms like in a cookie cutter home we had? And it has the big rainbow looking top, and then it has rectangle mirrors down below. It's like the day room upstairs. It had this big rainbow looking window, and I wanted to tint it before I left. I was up on the ladder, and I started coming down, and the film was falling, and as I stepped back, somehow my foot was on one rung with a rung in between it, and then the other rung I was bracing with my knee, And when I did that, it flipped my patella. I mean, I felt it move completely around the side of my knee as I came down. And anybody who's done that knows then I about threw up because that was some pain. It hit the ground. Well, it was actually my right knee. And that's fine. I got up and I straightened it back out. I kind of pushed it back over. Then I couldn't run. I'm deploying in 2 weeks, and you got to get ready. The first thing you're doing is getting a PT test when you get to Fort Riley. Anyway, no, it was anything that time. I don't know, it doesn't matter. And I'm trying to run, but every time I run, my whole knee gives out. It weakened it so much. And so I went and bought that Walmart brace. I'm talking about, that's what I said, it really was nothing. And I wore that for 2 weeks and then got there. In fact, I never told the military. I wanted to deploy. Anyway, so I did the first month up there of their PT and pure pain trying to strengthen my leg up. Don't do that. Just take a knee and get it. Take a knee. They needed me. Truth be told. I volunteered to go replace a PA. Picture one of you in here that y'all like these people. I didn't know this guy, but I knew he was stuck in Kosovo. The unit that he went there with, the next unit showed up without a PA to man the clinic, and so his unit left him there with him. And he had been there like 4 months longer, and this tasker came out saying, does anybody want to go replace this guy? And I said, I'll go replace him. And then I got stuck there. I'm like, anyway. I did it for a good reason, so I couldn't get hurt. I had to get this dude home to his family. That's the only time you're going to hear me act like I really care about people in here, okay? Kidding. Okay, let's finish. If you don't know anything, I'm digressing because it's more fun to talk about these injuries than to say, if you've been around the military, we know that patellofemoral pain syndrome is going to be worse after sitting for a while because your muscles all tighten up. It's going to be worse when you're going downstairs because you're putting a lot of pressure on that knee when you're doing that. It's going to be worse when you're squatting something, trying to come back up. It's going to be worse when you do a patellar grind test. That's where you have somebody sit straight leg and you lock their patella down and then say, okay, now contract your quad. You're going to hold the patella. If they have degeneration under there or some rubbing heat going on in there, they're not going to like that. Patellar grind test hurts whether you have or patella problems or not. Okay, so here's the answer and then we'll take a break. This is what you should avoid so you don't get runner's knee. Constantly walking, running, or jogging on the same side of the road. Sorry, Army, you gotta suffer. That's not gonna stop, right? Running on the same side of the road, if we run just like cars do, and you're running, you're actually, this foot, when you're running on the road, this foot is lower than this foot. Remember when I talked about leg length discrepancies, even 1/4 of an inch can make a difference? So if you haven't realized it by this point in your life, how old were you when you finally realized that most roads are sloped off the middle to help the water run off? And so when you run on the same side of the road all the time, this leg's higher. You're throwing off your center, and so that can cause, particularly put stress on the knee. And then you can see at the bottom there, it's because you don't get a full extension of your stride. Don't run on hills. Running long distances. The only one that you can't avoid in the military is you can't, we generally don't have knock knees anymore. Most people grow out of that. But everything we do in the military leads us towards that. I only threw the Army in there because the Air Force, when I told you, when I got to MacDill Air Force Base, and I saw they had a sponge track along the beach. I keep saying, I'm honest, I was so jealous. So jealous, but then I got them back. Because when I was at MacDill Air Force, do y'all have to take a graded, the Air Force does take now a graded PT test, right? And that started back in about 2003. You know why I know that? Because it was a big deal that only 2 Army PAs were at MacDill, and the Air Force were all talking about, we got to do this PT test. For us, oh man, we do it all the time. No, this one was going to be timed, it's going to be graded, we got to do this. And so me and him went and sat the day they did it on the side of that track where they ran, eating donuts. Watched them do it. So now you know I'm like that. Take a break.
That's not the right one. No, this. I got it. That's not the right one. It's kind of tilted forward, you know. I mean, it's either you or Wesson. This is the real time. This is the real time.
Alright, you already had one up. Oh, he took it.
But,
Yes,
no,
no,
I have it on my octopus.
Yeah.
And I have the sapper. Because, you know, sapper's the way, not Rangers. Rangers give us all lost. And he switched it out and put his Rangers out. I was trying to see how long it took. It was 2 days.
Yeah, I'm that. Not that attention detail.
Yeah, I like looking at it. I was like, because they're so it's like they're the same length. Yeah, they're like, I was like, okay, I was like. Yeah, so there's some that like the colored ones, like the yellow ones, are so they don't stitch you in because you don't think it's there. Yeah, ours aren't close ones. They're what did you notice? It's like this is not real tapping. Yeah. You're Wesson, because Wesson and then I mean Jake probably went there, yeah. Jake doesn't have time. So, yeah. That's all right. After the rest of the trip. You got Jake crazy. Honestly, I think you played the first game. And then he's on pressure the rest of the time. We're all like running up cool man. I wonder what that means. Shoot. Luckily, we have one of the dads who really does.
Lay down like on a solid surface, and if I was to lay here, like this way, and then I could bring my leg back, and this leg's still on here, I could let this leg hang, and it'll stretch your IQ back. Why do you just lay there? That makes sense. I need it longer. Like this. Hey, and then then you're gonna allow that to just hang down, and over time it's gonna stretch that.
Then I will have to face the back differently.
Hearing in front of your doctor. Says like, yeah, I just like, gosh, how far out did you stay? And you did something without carrying it. I guess if you had really loose, yeah, it's just like in the hands. But like, as soon as you like, especially like that, it's not a wall, it's soft, it's soft. I know, but like as soon as you have that shear, like, yeah, ACL, yeah, depending on which direction. I hate these hyperextended reps. See, like, imagine this is my medial side, where my thumbs are. This is where you step and then, like, grab lap. If somebody comes in from the side without you, and you do that, and that's like 5 minutes. Goodbye, sweet world. You know, usually, yeah. Well, that was my undergrad. Never got to, so I didn't do my the master's undergrad. I think I would just because like if you goes down, I said I was able to become that was but yeah, because everybody else was like OT, PT, this all this different stuff. It's just cool to be around people who are like that's like their passion. It's like trauma too. Yeah, actually do it's like sat down oh my head. Yeah. Unless you're in the one college, your physical therapy is not always highly motivated athletes when you get back in the game. They're just like people who have a history of the body and they're not strong. And you're trying to tell them how to build strength and capability. It's not even high school. My high school trainer, I'm still he was actually congregation. Oh yeah. But really dude, always but they don't
Who's he running from? I don't know.
what SBI part of it. He was awesome. And he would so in high school I thought he would let us come in and do assessments and that was actually part of it. Go ahead and do that. Tape. I was gonna say probably take a lot. They do ultrasounds on people and athletic department. It was actually not like but you're actually you're actually I think that stuff. If this doesn't work out, do it. Our guy was also in sports. Then you get coverage, like you get student trainers or whatever. Always there until like 5 or 6, or like some teachers he also was for like the on the sidelines are like running out at one of the games. That's all super my cousin especially children specifically like a gymnastic that's her passion. She gets like all the cheerleading. I think about trying to be a physical therapist. Your shoulders need to work, Dave. We'll address this at another time. This discussion is here. That's so you. Oh, just say let's get to it. He's taking everything with castor oil and rubbing on. Castor oil. On my hand. I don't know what exactly.
Children guys go out for observers. Y'all go see if you can find some contact.
Speak on my heart.
I had a blast. Right then, I really had fun. We jumped in the helicopter. Fly us out to like Tampa right before our and then drop us off, and then we'd have to march back. I hope we I didn't do that guy outfit or something, but they did that all the time. It's a good unit to be in first. It kind of sets the tone. Infantry, cash scouts, we do that first. The rest of the military is kind of a joke. You know, it's not a joke, but there's nothing they can do to you that you already know how to do military type stuff. Or if you go to like you're a medic, you go to a high first assignment. So I think that's why they leave them there this time. It used to be if you were like a medic in the infantry, your next assignment would always be in infantry. You wouldn't switch into a hospital unless you fought the infantry. The hospital ones would never get the infantry. You gotta out and do something. But hospitals are better than their own. At least my experience. They're gonna write these out. They're always getting promoted. They're all they play this game better than the free side.
If you want to stay like on the ground with the guys, try to make it to major, maybe higher than that. For us, we ended up artillery. There was like one E7 slot in the state, like one or two E7 slots for all the section chiefs and stuff. E6 is maybe an E7. E6 is back when you get on the field. And then it goes time higher. Yep.
I think the AC went out. Hot and
Musty.
Alright. Getting closer. So we start back with observable features of the leg. Most of us understand what our calf muscle is, our gastroc medius. But we also have soleus that's deep to that. So these are going to be posterior compartment muscles associated with the leg. You can see it very large, I noted it, great saphenous vein here. And then of course your calcaneal tendon. Other features we can see, the distal portion of your medial, or your tibia, is your medial malleolus. And the great saphenous vein, when we described it earlier, we're talking about it goes in front of that medial malleolus. It'll go up the leg and then it'll tuck itself, kind of wrap around the medial condyle of the femur and then back out to the femoral vein. Go to the lateral side, we can see the distal end of our fibula is our lateral malleolus, and our small saphenous vein runs behind that, or lesser saphenous, and empties into the popliteal vein. Main observable features, you can see like the extensor tendons and all on the foot, of course, but I didn't throw slides in there. So here's our compartments for the leg. I think the AC went out. I feel a little cool air going, but it's really muggy in here. Maybe I'm getting nervous. Anterior compartment, lateral compartment, and our posterior compartment. Like I said, the leg to me is easier than the arm, but these are just generalities. So the anterior compartment's job is to dorsiflex the ankle. Dorsiflex the ankle means like taking your foot off of the gas, bringing it up, or standing up on your heels. It also, anterior compartment muscles help to invert the foot. They can help extend the toes, and then they're going to be deep fibular nerve. In these compartments of the leg, there are going to be 3 compartments that we see associated with the leg, and the innervations will only be 3 different ones. So every muscle in each compartment, there's not going to be exceptions, like we saw with the upper a little bit. The lateral compartment is our main everters of the foot. They can do weak plantar flexion. Plantar flexion is where you stand up on your toes or you push your foot down on the gas. And in the posterior compartment, and they're all going to be superficial fibular nerve. This is, remember when we got to the radial nerve and I said, I don't need you to pick up on whether it's deep radial or just radial. And I said later we'll have to pick one out. And here in this case, I need you to know that like the lateral compartment is superficial fibular, the posterior compartment is tibial nerve, excuse me, and the anterior compartment is deep fibular. So the anterior compartment and lateral compartment are both fibular, but the truth of it is what happened is we had the tibial nerve, let's back up further. We had the sciatic nerve that divided into the tibial and common fibular nerve. And when the common fibular nerve enters the leg, it's going to divide into the deep fibular and superficial fibular. Tibial will still innervate the back, but the lateral and anterior compartments are going to get a branch of that fibular. And so I do need to know the specific branch, deep or superficial. I didn't want y'all to go and ignore that. All right, so here's a photo that it's not one you diagram, it's not one you ask questions on. It's just there to show you the kind of muscles and how the compartments are set up. On the top there you have your anterior compartment with the list of all the muscles in it. You have your lateral compartment out here. And then you're going to have a deep posterior and a superficial posterior. And I just listed it that way with all the muscles out to the side. This is one of those pictures where everything's in the slide if you don't like the way this is set up. So here's our muscles of the anterior compartment of the leg. Tibialis anterior, the extensor hallucis longus, or the long extensor of the great toe. Extensor digitorum longus, the long extensor of the digits. And then you have fibularis tertius. I think next class I'm going to find, I may cut out peroneus, because these fibularis used to be peroneus tertius, but we transitioned that name, so it's fibularis. Fibularis tertius is an anterior compartment muscle. So all of these are innervated by the deep fibular nerve. When you look at the muscles themselves and how they tie together, all the muscles are held together firmly, like it says, in a compartment. That's why we can have compartment syndrome. The fascia is going to get thicker as it gets down towards the lower part of that extremity and becomes the extensor retinaculum. Actually, there's two of those. And the you don't memorize this. AKA crucial. I don't want to confuse you with the knee. Here's the point. The fascia of the leg, just like we saw in the arm, will come together and make extensor retinaculum, and there is a posterior retinaculum associated with that. It's not truly called a flexor. They will make retinaculum. The only thing I want you to realize is they're there because they're helping to hold the tendons down. We're not going to talk about them like we did in the wrist and figure out what's going under what. So it's just there to say, yes, they exist. So here's tibialis anterior. And tibialis anterior originates off of the tibia and the interosseous membrane. So knowing that tells you that it has nothing to do with the knee. But it does cross the ankle and it goes down to insert on the first cuneiform and first metatarsal. Right, so that's that muscle you can feel right along where you get shin splints, right? Down that tibia. Its job is to dorsiflex, take your foot off the gas, and look at how it's angled this way. And if it pulls this way, that's going to invert the foot. I always use my hands when I'm talking about the feet up here. Just make sure you know what we're talking about when we use these words. If there's your foot, I know I'm going Barney here, right? Big blue, purple Barney. Was he purple? We're going Wiggles. I'm going to use Wiggles. More people know the Wiggles. Wiggles style here, just basic. Dorsiflexion, plantar flexion, right? Then you have inversion, right? I'm turning it this way, doesn't move much. Then you have eversion, which is turning it out. So if you think about the difference between eversion and inversion, everybody in here at some point has, at some level, has sprained their ankle. That was an inversion motion sprain. Now somebody in here may have had an eversion sprain, but most time you're going to roll your ankle, and that's inversion. I'm just trying to explain that because I don't want to assume that everybody knows that. Right. So this is going to be deep fibular. All the muscles of the anterior compartment are deep fibular. Extensor hallucis is the longest, originates off of the fibula and interosseous membrane. It's going to the great toe because it's called hallucis, so longest. It inserts at the distal phalanx of the great toe. So its job is technically, I don't know why I keep using that word the last few days. Its job is to extend the great toe, and because it crosses the ankle, it will also help with dorsiflexion and injection.
I just want to clarify on the inversion part, because the slide up on 180, that makes it look like that would be pronation. Is that, is pronation and supination like turning it out and in versus?
You got me. I'm saying that because I had changed slides on one thing. You just made an excellent point. And I'm going to explain it. Because I was going to take that out for this class. When you look at eversion, inversion, yes, they look at supination, pronation. We would think of it like that way. The reason I didn't want to get into the deeper discussion and where you're going with that is, when you look at supination, it's a combination of muscle actions to cause that full motion versus just pure inversion, as they describe it. And so there's a difference between describing what happens with supination versus inversion. Inversion would be technically just turning it in. Supination involves even turning the toes up into. And so I used to describe that, but I decided not to. So normally there's about 3 muscles that are going to help you with supination, 3 that are going to help you with pronation, but I want to leave it to where, hey, let's just talk about eversion. Right. That's That's a good pickup, because I didn't even notice that was still on the slide, but those are motions that are associated with foot. Like I said, I just didn't want to go into it. So, good catch. Reason being, I took that out, in case you're wondering, is it does make a good question when we don't talk about it that way often in clinic. So you were memorizing the muscles responsible for supination before, when it's something you weren't going to ever be asked again outside of here, so I took it out. Unless you're an ortho, maybe. Okay, extensor digitus, longest, I already got that whole slide. Extensor digitorum longus, long extensor of the digits, originates off of the tibia, the fibula, and interosseous membrane. It does not cross the knee, so no action there. It does cross the ankle, so we know it's going to have some action. Then it inserts into the dorsal surface of the 2, 3, 5 digits, distal phalanx. That helps them to extend, so you can extend toes 2 through 5, and as it crosses the ankle, it also helps to dorsiflex the ankle. And still, like all the others, it's deep fibula. And then you look at the last one here, fibularis tertius. People often try to put fibularis tertius in the lateral compartment, because once you understand these better and you're studying them, you're going to associate fibularis, that word, with the lateral compartment. Because the lateral compartment only has 2 muscles in it, and they're both named fibularis longus and brevis. And then you throw in fibularis tertius, and people will say, well, that's the lateral compartment, all the fibularis type muscle. No, fibularis tertius is an anterior compartment muscle. And I'll show you the difference in the picture, but it originates kind of low on the fibula and interosseous membrane, and then it's just going to insert at the base of the 5th metatarsal. So dorsiflexion of the ankle, and helps to evert the foot. Our lateral compartment, we only have to worry about 2 muscles. That is our fibularis brevis, fibularis longus. Both of them will be innervated by superficial fibula. If you can't tell by now, I do not care if you know the perineal part, parentheses part. I've really been leaving it in there because there's people who learned these muscles a long time ago still coming through the schools, and they're like, I've never heard it called fibularis, but it's fibularis. My wife's the same way. She refuses to use the word. She says, no, it's peroneal brevis. That's not the way they call it nowadays. One of the things we dispute all the time. Okay, fibularis longus. Fibularis longus originates off of the fibula. It inserts, and this is a unique insertion. It inserts at the first metatarsal and first cuneiform medial plantar surface of the foot. Okay, let's look at where it's at. It's on the lateral side of the leg. It's originating up here by the head of the fibula. Its tendon is very long, and it comes down behind the lateral malleolus, goes to about the base of the 5th metatarsal, but then it's going to go under the foot and insert on the plantar surface of the first metatarsal, first cuneiform. So this muscle is able to help you evert your foot, possibly help you. Remember, lateral compartment are weak plantar flexors. So if this muscle contracts, it can help plantar flex somewhat because of the way it's set up. But it's a big evert. Let's look at, this is the bottom side of the foot. Here's your calcaneus. If we go back and for reference, this came down, went here and said, well, at this point it's going to go under the foot, flip the foot over, and continue it. It's going to come under and go all the way over to the base of that first metatarsal. The reason I'm pointing that out is because that makes it a good, strong everter, but it also helps to keep your transverse arch that we're studying. So that muscle helps with that transverse. All right, fibularis brevis, the other muscle of the lateral compartment, originates off the fibula. It inserts into the base of the 5th metatarsal. It everts the foot, the ankle, plantar flexes at the ankle, can evert the foot. It's superficial fibular, and it's also a muscle that when people roll their ankles sometimes, that can tear off or it bulges off of that base of the fifth metatarsal, along with the ligaments that we haven't talked about yet. So this is the base of the fifth metatarsal. So if we look at how these muscles are set up, remember if you look at tibialis anterior, or anterior tibialis, it inserts on the dorsal side of the first metatarsal, first cuneiform, and it dorsiflexes the foot, brings the foot off the gas. If you look at fibularis longus, it inserts at the plantar surface of the first metatarsal, first cuneiform. So these two muscles are actually antagonistic. Now we haven't done the posterior compartment of the leg yet. In the posterior compartment of the leg, we have a muscle called posterior tibialis. So you'll hear, okay, well that, in your mind, you go, well, then anterior tibialis and posterior tibialis must be antagonistic muscles. And they're not because of the way they function. The two antagonistic muscles are tibialis anterior and fibularis brevis. Or sorry, longus. You don't have to spend so much time trying to figure that out. I just like to note that when we go through because it's different. Right? When somebody starts talking about those muscles, anterior tib, posterior tib. So here's our posterior compartment muscles. So we have a deep and a superficial group here. All of the superficial group muscles are the muscles that we normally talk about, gastrocs. And they have normally, most of them have a common tendon insertion that's going to the calcaneus, right? The Achilles tendon. When we look at those as a group, every one of them is going to get innervated by tibial nerve. So once again, all of your posterior thigh muscles, all of your posterior leg muscles are innervated by the tibial nerve. And here is gastrocs. Its origins now go above the knee. Remember, it forms part of that borders of that popliteal little triangle there. So you have the lateral and medial femoral condyles where the gastrocs originates, and the two heads will come together into one tendon called the Achilles tendon or the gastrocs tendon and tie into and insert to the calcaneus down here. So now we're doing the opposite actions where this muscle, if you contract, is going to allow you to line up on your toes, allow you to plant a very strong plantar flexor. Right? But it also crosses the knee, so gastrocs is involved in knee flexion also. It's not a big player there, but it is involved. And then you have your tibial nerve. Soleus is the next muscle we see in this compartment, originates below the knee joint, so tibia and fibula. It's going to insert also into that same tendon that the gastrocs did. Soleus is going to insert into that same Achilles tendon and make its way to the calcaneus. It's not going to have any action on the knee. It's only going to be able to do plantar flexion. Here is plantaris. So plantaris, similar to gastrocs, originates above the knee. So we're going to say that it may have some knee flexion. But this is a very small muscle, and sometimes its tendon is used to graft out for other surgeries. But it has an insertion on the calcaneus, but technically it's not part of the Achilles tendon. Right? So plantar flexion, this is going to be a very weak plantar flexion with this muscle, very weak knee flexion. It's just a smaller muscle that's there. And the only thing I can think about is my brother-in-law still has this tendon, but he tore his main Achilles tendon and he decided not to do surgery on it. Because I guess he decided I'm just not going to do anything the rest of my life. He went down to the well, we have a ranch house down at the bottom of my property. He went down to the well house and opened it up, and these bees all came flying out. And he leaped back like 5 feet and tore his Achilles tendon. I give him a hard time still. Like, you just jumped and you tore your Achilles? Because he doesn't, you don't want to hear that. He's a good guy, but, yeah, he didn't let it, they just let it heal. Because he's not real active, but he still had his plantaris intact there. So he can still walk around and stuff. I don't know why he didn't get it fixed. Alright, popliteus. Popliteus is a very small muscle that originates off of the femur, and it's going to insert on the tibia just superior to what's called the popliteal line. I'm going to throw a little bit of a curve here. This is another thing saying supination and pronation that we're not going to talk about. Is what two motions does the knee joint do? It is a synovial joint flexion and extension joint. It's a hinge joint. What is this? This is a muscle in the leg, and what is it saying it does? Rotates the knee medially. I said, I could change both the first letters there. That was very much having a stroke. Rotates the knee medially and flexes the leg on the thigh. That medial rotation is something that you might want to discuss when you get into like ortho. But what we find, and I'm just going to tell you this and move on, don't write this down. Even though this is a flexion and extension joint, when you just before you get into full extension, you have a slight degree of this medial rotation. Advanced ortho, you can go in and talk about that and what's happening with that when you go into full extension or locking your knee out. Here we just got to realize that that's what it is. And the fact that this is a landmark, when we get to the arterial supplies, we're going to see that the inferior border of this muscle is where the popliteal artery that came through the popliteal fossa is going to split the anterior and posterior tibial arteries. So we're going to use it more as a landmark. And we're not going to discuss the biomechanics of any extension of any, like any rotation. Alright, so we get kind of into the deep group, and you have tibialis posterior. Posterior tibialis, tibialis posterior, you can say it either way. Originates off the tibia, fibula, and interosseous membrane. It's not going into the knee. These are most of these muscles that we're about to look at are going to be part of what's called the tarsal tunnel. And they're going to have a mnemonic that goes along with it, Tom, Dick, and Nervous Harry. So this muscle makes its way down and goes medially behind the calcaneus. This area here is called the tarsal tunnel. It's going to go through that, and it's going to insert everywhere. The metatarsal of the foot, second, third, fourth, the navicular, the cuneiforms, the cuboid. It inserts in almost all of your tarsals. And it is a very strong plantar flexor, and it will help to invert the foot. So it can help to bring that in. So we see our tibialis posterior being this muscle tendon here. Hang on to that thought. Then we have in that same area, we have flexor digitorum, which originates off of the tibia. Goes the same thing through the tarsal tunnel and will insert into the distal 2, 3, 5 phalanges. So it can plantar flex and help to flex your toes. It's how those people that go and use their toes to like pick stuff up. I heard that drives people crazy. You know what I mean? You see somebody that go pick up a sock with their foot or something? Nobody wants to admit it. Okay. I don't know how you do that. You did it? Yeah. I just didn't know you did it. Thanks for playing. But you're going to be better off than me when you lose your arms or something, though. Come on. You'll be signing checks then. I've seen somebody do that. That's awesome. It's amazing what we can overcome in life. Hey, flexor digitorum longus, I just tried to wake you up. Flexor digitorum longus, still tibial nerve. Here is flexor hallucis longus. You didn't have enough of these yet. It originates off of the fibula, inserts into the distal phalanx of the great toe. So it's going to do flexion of the great toe, and it's a smaller muscle, so it's not as strong of a plantar flexor. I keep saying whether they're weak or strong plantar flexors. I don't need you to key in on that. I'm going to ask you, oh, you didn't know that was the weaker one? We're just going with actions. Remember, if it says it flexes something, it flexes it whether it's weak or strong. I felt like I was leading y'all towards thinking that way. I don't care if it's a weak, strong, it does that action. And it's still tibial nerve. So we're gonna come back, I don't know if it's today or tomorrow, if we get to it, and we'll look specifically at the contents of the tarsal tunnel. And I'll show you how these muscles line up with the arteries and nerves. For now, we're just getting through the muscle slides of that. And I know that because we're on the blood supply to the leg. Alright, so every time you do blood supply, you kind of got to back up and go, well, we had, I repeat it, we had the sciatic nerve. Sciatic became tibial and common fibular. The tibial nerve went straight down through the popliteal fossa down into the lower leg. The common fibular nerve went and wrapped itself around the fibular head, and then it divided into the anterior and posterior, anterior and lateral nerves. We had superficial fibular, deep fibular nerve. Well, the arterial supply splits a little bit like that at the knee because you had your femoral artery. Well, we could go all the way back up and say we had an external iliac artery that became the femoral artery of the inguinal ligament. The femoral artery became the popliteal artery once the femoral artery went through the adductor hiatus to the back side of the knee. And now the popliteal artery at the inferior border of popliteus, however you'd like to say that, will divide again into posterior and anterior tibial arteries. Posterior tibial artery will go completely down to the foot, and it will become the medial and lateral plantar arteries. Anterior tibial will go to the dorsal side of the foot, and it will become dorsal pedis. So that's as far as our arterial supplies are going to go. And so if we come back up here, we have our common action. I'm just going to go down to the foot. We already kind of understand the external iliac, femoral, popliteal, and then we have the division. Anterior and posterior tibial arteries. That posterior tibial will become medial and lateral plantar arteries, and the right anterior tibial would become the right dorsal pedis. And that's the only ones that we had to know on this diagram. And we know the external or the internal iliac goes to the pelvis and the gluteal muscles. So if I'm going to ask you to label anything, you know it's not going to be that schematic. It'll be on this picture, which is probably in your study pics. So be familiar with the ones that we talk about. I'm looking down. When I say that, I can go down and say, well, sorry, it's small on the screen. Here you go. Do not go any further into the arteries of the foot other than saying that you have dorsal pedis on the dorsal surface, then you have medial and lateral plantar arteries on the plantar surface. That's it. Don't do the arcs, the digits, all that kind of stuff. On the venous side, okay, we're going backwards so that they're named the same here. We had our two superficial veins, but now we're looking at all of them together kind of, and we can start with superficial right here. Right, great saphenous, small saphenous empties into the popliteal. Whoops. Great saphenous empties into the femoral. So when we get into the deeper ones, we're going to see that we have our medial and lateral plantar veins. It's going to enter into posterior tibial. We have the right anterior tibial coming up. And all of those will come together into the popliteal, to the femoral, to the external iliac, to the common iliac, ultimately to the inferior venous. That's our progression. Like I said, leave all those dorsal venous arch stuff out of it. And then just correlate them to this picture. So be familiar with how to. I just kind of drew in general, but I don't have anything boxed on here, but this helps. I'm trying to help you out here. trying to help you out ones that I'd be expecting labeling. But I guess everybody's sitting down there writing something, so I guess it's trying to narrow it down for you so you don't go waste your time on all those arch veins. Sorry, see where we're at. Alright, we're good. Here's your side. Remember this drawing we had before, and just keep keying in on that, but there's sciatic to tibial and common fibular. Tibial, medial and lateral plantar nerves, common fibular, the deep fibular, and superficial fibular. Then you can go back in there and add in your muscles. I don't have any more to say about that. Here's another example, once again, this picture of your tibial nerve going straight down and supplying all of those muscles. I put that there so I could talk a little bit more about, I put that there, lead us into common fibular nerve and nerve. Okay. So I know it seems like we keep repeating these, but the common fibular nerve makes a kind of a wrap around the fibular head. So the common fibular nerve, and I'm going to develop this kind of into a scenario, but when you look at the common fibular nerve, its job is to provide the branches of the deep fibular nerve and the superficial fibular nerve. The deep is going to supply the innervation to the muscles of the anterior compartment, and the superficial is going to provide the lateral compartment. So we want to think about this because people injure this nerve more often than others. And what do? They are walking, and they call this the coffee table nerve. As you picture your fibular head being at that level, right, and that nerve wraps right around here. And so if you hit that area with the coffee table, as you walk by it, you can damage that nerve. So what would happen, you think? Let's say that I have I got to set it up to be easier. I have I'm trying to give you some relevance while we learn these things. I have a coffee table that is, I don't know, sharp glass on the edges. How about that? So this is set up to perfectly just wound you. And you walk by and you hit that fibular head on it, and you wind up severing the common fibular nerve. What would you expect to lose? So I said inversion, but you would lose definitely the ability to dorsiflex. Because you just took out your anterior and lateral compartments. So you would not be able to evert your foot or dorsiflex it because those muscles wouldn't be working. Now that's the way you got to think about it more clinically. So people who damage their common fibular nerve or irritate that nerve often going to feel things in the anterior portion. They can have weak dorsiflexion. So it's called common fibular nerve injury. I already talked about that. It can be stretched, torn, anything that happens when you do that. So this severance, if you were to completely sever that, this is what I was saying, all the anterior and lateral compartments no longer will work. So the dorsiflexors and the everters, and you develop what's called foot drop. So your foot's going to slap the floor when they're walking. So here's what the patient's going to look like. They're going to have to raise their knee much higher than before to clear their foot. We haven't studied gait patterns, but when you walk and you take a step, right, you're going to step, you're going to lift your foot up, and when your foot's coming through, your toes are down, but you actually dorsiflex and bring them up. I know not all y'all can see that. You can see the person in the picture that as this leg swings through forward, the toes can't stay pointing down. You need to dorsiflex to clear. And if you can't dorsiflex, you need to raise your leg higher by using your knee. And what's going to happen is when that comes back down, so they can't walk normal and swing. When it comes up, it's going to be and just slap their foot down because they cannot dorsiflex. Because as you think about gait valves, when you're walking, if you hit heel first and then you roll over on your foot and push off, this person cannot hold that foot, so it slaps down. They really don't have any push off after that. That's called a common fibular nerve injury, produces a clot. May or may not have sensation after that. It depends on how severe it is. It could be chronic irritation of that nerve. You're going to hear that again in physical exam where damage to the common fibular nerve. Alright, the last thing we're going to talk about today. Deep fibular neuritis is because the deep fibular nerve innervates the anterior compartment. But it goes on to provide the cutaneous sensation between the great toe and the second digit. And so it goes in front of the ankle and crosses right where we see our extensor retinaculum. So basically, it crosses the part of your foot and ankle where most people tie their shoes. And then it goes on into the foot to supply extensor hallucis brevis, extensor digitorum brevis, and then cutaneous sensation. I want you to line out these two points. Those are muscles. Those are intrinsic muscles of the foot. And we're not going to study the foot in that great of detail in regards to those. We're going to study conditions more. But we do need to know that deep fibular neuritis is going to present as numbness, tingling in the foot between the great toe and the second digit. Because that's where the deep fibular goes on to provide that too. So it's an entrapment neuropathy, and a lot of times the people that get this are the people who like go out to run and they'll tie their shoes much too tight. Right? On top of that, it starts to irritate that nerve, certain boots. And you'll see that present. So people will come in saying, I'm going to see if there's a, should have went the other way. Definitely should have. There we go. This area here. So the deep fibular nerve innervates all the muscles of the anterior compartment of the leg, and then goes on to run down to provide the cutaneous sensation for that little triangle area there between your two toes. And so when you compress it up here, you start to see people come in and say, I have pain, numbness, and tingling between those two digits. Once again, I'm mentioning it because it's more common. It's not normally detrimental, going to take you out kind of thing, but you'll see it presented. Okay, so that's where we will stop today and pick it up tomorrow. Made it through another day. I hope y'all do well on your hands-on exams tomorrow. Just remember always that you got it. Actually, remember this. Only you know if you put in the effort. And you did, so good luck tomorrow.